Welcome to this urban talk on health in cities entitled Opportunities and Challenges for Urban Health and Wellbeing in a COVID Environment. I'm quite pleased to see many familiar names and many names that I don't know yet that are new. I think we have a nice mix of representatives from international organizations, states, cities, NGOs, academia, the private sector, as well as individual experts, and people keep coming in. My name is Antu Duong. I am a senior policy advisor here at the Geneva Cities Hub, and I'll have the pleasure to moderate this event today. Just in terms of housekeeping, the event is being recorded and then it will be put on the Geneva Cities Hub website. Please do not hesitate to use the chat box to ask questions, make comments during the discussion. I hope we can have an interactive exchange today. And before giving the floor to our distinguished panelists, I would like to give the floor to Daria Cibrario, the Geneva Cities Hub Director, to make some introductory remarks. The floor is yours, Daria.
Thank you very much, Antu, and good morning, everyone. A warm welcome to all of you panelists and participants alike. It's a real pleasure to start our series of urban talks today. I would just like to really emphasize what Antu has already said. In our panel, we will have a mix of distinguished speakers, including representatives from local governments, but also experts from academia and from Geneva-based international organizations. And in our public, we have an even much wider mix of stakeholders. This is precisely what the Geneva Cities Hub is also about. We are a new platform in international Geneva aiming at bringing together stakeholders and experts in urban issues within the international Geneva community to exchange good practices, to have debate and to cooperate on urban and city related issues. So this is really one of our main missions. But at the same time, as we build this community of experts and practitioners in international Geneva, we aim at connecting them to the wider international municipal community comprising local and regional government representatives, cities and their city networks, plus the whole plethora of civil society gravitating around urban and city issues. And we also aim to support these actors as they seek to contribute and participate much more in multilateral policy making in Geneva-based organizations. So I just wanted to flag up the role of the Geneva Cities Hub because we really value your participation and your contributions, and we hope you will continue to engage even more with us. We expect also your input. Do not hesitate to tell us which are the key issues on urban and city-related topics which are of interest to you, and we can build this kind of debates around those to everyone's benefit. And now, without further ado, let's begin this important conversation aimed at looking at the critical connection between cities and health. We all know by now that over 95% of COVID cases have been found in urban areas, and that therefore cities and urban areas are bearing the brunt of the pandemic. What is less known perhaps is that as this tragedy unfolds, local governments have actually turned it also into an opportunity to improve the urban determinants of health. Many of you will have heard about the so-called 15-minute city, whereby in 15 minutes walking distance, there's an understanding that urban dwellers should be able to access vital basic public services, but also perhaps the Milan's now flagship program called Open Streets, which has expanded, for instance, bike lanes and enhanced public transport precisely to keep distancing, but at the same time also favor physical activity. We will hear from local government representatives about the examples and the measures taken in their cities. And with that, I really wish you a fruitful and interesting and rich discussion. Thank you very much, and over to you, Antu.
Thank you, Daria. So today's discussion, as you mentioned, is focused on the urban determinants of health. Of course, the issue is far from being new, and there's been a lot of work and research on it for many decades. Indeed, the environment in which we live has always had an impact on our health. It's almost intuitive, I would say. However, the issue has not really been on the top of the health policy agenda here in Geneva for two main reasons, I believe. First, urban determinants of health encompass many areas and many actors. Almost everything has an impact over health. So where do we put the limits? And in terms of actor, we of course must go well beyond health experts and include urban planners, architects, all the administration providing basic public services, etc. So the many areas and many actors make it very difficult to work on urban determinants of health in the traditional and very siloed way we work. The second reason why determinants of health do not get much political attention nor funding is probably because the priority has usually been put on curative treatment for specific diseases rather than on upstream prevention, which is a concept that remains difficult to operationalize and to measure. However, things seem to have changed with COVID-19, and urban determinants of health have taken on a new spin. Everyone in the last year has come to realize that the way we live in urban settings has a big impact on the way that the infection is spread or prevented, on the way we experience confinement, restriction, on the way we can preserve mental health. So we have today gathered great experts, city leaders, to provide us with their views about what those determinants of health are, why there are opportunities to seize and challenges to face in times of COVID, what are the concrete examples of measures taken to improve determinants of health at city level, what works in terms of multi-stakeholder and multi-level approaches to improve the determinants of health in a given cities. So the very distinguished speakers we have today are, to start with, Dagur Eggertsson. He's the mayor of the city of Reykjavik in Iceland. We have Anuela Ristani. She is the vice mayor of the city of Tirana in Albania. We have Charlotte Marchandise Franquet, the former deputy mayor of the city of Rennes in France. Graham Alabaster, who is the head of the UN Habitat Office here in Geneva. And Monika Kosinska, who's the regional European focal point for the WHO Healthy Cities Network. And to start with, I'd suggest that we'll watch a video message from Professor Evelyne de Leeuw, who is really one of the world's leading experts on urban health. She has kindly accepted to introduce the concept of urban determinants of health for today's meeting.
Hello, my name is Evelyne de Leeuw. Some of you may know me. I do stuff around health, political science, urban health, healthy cities around the world. I'm honored and delighted to have been asked to give a brief introduction to today's session. As I have a history in healthy cities, I think I would be well placed to reflect on a few things before you kick your session, your important session off. But why would cities be bothered with health? Why would local governments care about health and investing in health in international diplomacy? The answer to that question is the determinants of health. This is the picture that was made famous by Göran Dagur and Margaret Whitehead, and it describes how people are driven by their own age, sex, and constitutional factors when they're healthy, but different areas, peels of the onion, so to speak, of lifestyle around that, and lifestyle is determined by social and community factors, which are driven by living and working conditions, which are shaped by general socioeconomic, cultural, and environmental conditions. Now, this already shows how cities shape most of what determines our health. Sir Michael Marmot, a famous figure in the international discourse around determinants of health, created a slightly different perspective on this in work that he did with a large commission for the World Health Organization. And he looked at all of these things in a slightly more complex and abstract way. And he looked at governance, macroeconomic policies, social policies, public policies, and values as the structural determinants of health and the social determinants of health inequities. And again, you would almost immediately see how local government has a role to play in these things. And then, of course, there's other factors about our responsibilities as individuals and as communities in shaping the context for health and how that impacts on equity in health and well-being. This was recognized early enough by the World Health Organization when they started shaping their Healthy Cities program. Trevor Hancock and Leeuw in 1986 were asked to write about the factors that create healthy cities. They did so in this little booklet, Promoting Health in the Urban Context, only 50 pages, but it is a rigorous review of the international literature, both in urban planning, in design, in city governance, as well as in health and the determinants of health. It was a very early but very visionary perspective. What they came up with was that cities can pursue 11 qualities if they want to make their cities healthy. And these 11 qualities are these. I'm not going to read them out here, but it ranges between a clean, safe, high-quality physical environment to the provision of healthcare services where that is appropriate in the local governance structure. It's interesting that of these 11 qualities, only 2 directly talk about health and healthcare. All the other factors contribute to our health and are shaped by city governance and by communities living in those governance areas. You might wonder, in the years that have gone by since 1986, has nothing changed? Of course, things have changed. There are differences, and we have moved into a new era, the era of the Sustainable Development Goals. And therefore, when they were launched, we were interested in mapping the Sustainable Development Goals against these 11 qualities. And we found an almost direct alignment between the 17 SDGs and the 11 qualities of a healthy city. When we go back to the original work by Leeuw that stemmed back to 1962, Len wrote about the city as a living, breathing organism. And if the city was healthy, the people in the city were healthy. It expands, it contracts, but with green spaces, with good mobility, with a healthy infrastructure, with a socio-economic situation that is good for all, you would in fact create a healthier city. Now, that brings us to COVID. We did actually write about healthy cities in the current age of COVID and the pandemic that is sweeping the world. We do think that this is a challenge for health and health equity, obviously, but we start to discover what the role of cities is in doing this right. We need to apply an equity lens to urban policy measures, and we need to consider cities as One Health reservoirs of zoonoses like the COVID virus. One of the things that is so clear about healthy cities is that it's only one of many networks around the world. We identified that WHO Healthy Cities in Europe was the first global network of cities to emerge. And there came a lot of others after healthy cities: sustainable cities, smart cities, resilient cities,
smart cities, inclusive cities, slow cities, child-friendly cities, age-friendly cities, happy cities, healthy cities, 2.0, creative cities, knowledge cities, festive cities, just cities, winter cities,
and all sorts of representative bodies on the right of this slide. And Benjamin Barber, an American political scientist, says that the world would be a much better place if mayors ruled the world and if cities would assume leadership. I say this is a mantra that the World Health Organization and UN Habitat have been spruiking for a long time now, and I think you need to make that leadership happen. How that would work, in fact, is the subject of your deliberations today.
Following this very good introduction by Professor Evelyne de Leeuw, which reminded us that cities shape most of what determines our health, we'll have the pleasure to hear from cities themselves, starting with Mayor Dagur Eggertsson, who will tell us about how the city of Reykjavik in Iceland responded to COVID and how the measures to address COVID, as well as broader measures, have impacted the determinants of health. Mayor Eggertsson, the floor is yours.
Thank you very much. It's an honor to be with you. Been mayor for some years now, but actually my background is in medicine, and I was going to study infectious diseases, pandemics, and human rights as a specialty field when I was hijacked into politics. And to my surprise, these have been kind of daily tasks most of this year. As some of you may know, Iceland has been quite successful in dealing with COVID in all international comparison. I think that is based on maybe three simple things. We prepared early. We based the response on science, and we used a systematic approach that could be called kind of emergency measurement planning. So as it's nationally coordinated, but the municipalities and city of Reykjavik are an integral part of it. We had the first meeting in the emergency board of Reykjavik with the chief epidemiologist in the end of January. So we had gone through all our preparedness manuals that we built up after the SARS pandemic, when we had the first positive COVID case in the end of February. We had activated kind of the emergency boards of all the cities and municipalities in the Reykjavik area from that stage. But in the front line, we've had the chief epidemiologist, the surgeon general, and the head of emergency management in the country. And they've been quite open and frank about the situation all the way from day one. And that has established a lot of trust within society. So they've been very open both about the uncertainties of the pandemic, on what we know about the virus at any point. When it comes to the city, our work has focused very much on how to implement the national guidelines with a clear focus, of course, on the vulnerable groups. So by being prepared early on, we managed to make a safe space for the old that we serve to a large extent. So early on, we closed down some of the social functions, but kept in contact with people through phone. So the people that on a daily basis before had social contacts in rooms and now have social contacts through phone or over a computer screen. We have expanded programs for homeless, so they also can use kind of social distancing and all the other measures that we have used. But what's really the fundament of this is not an Icelandic invention. We are just using the old classical handbook of public health of diagnosing, tracking, tracing, and asking people to be in quarantine. The National Hospital set up a outpatient clinic for all COVID cases, so they are contacted on a daily basis. So we try to kind of monitor the situation from day to day and use that data, of course, for measures. And I think that the extensive testing program, tracking program, and actually genetically sequencing of each and every positive case, so we know if there are new strings of the COVID virus around in society, has helped us to have much more oversight than many cities. Have been sitting on meetings with mayors in the States and Europe throughout the pandemic on a regular basis, and some of them have been saying, well, we are flying blind here. So that's why some cities have had no other choice than go into total lockdowns, while we have been able to keep the schools going and a lot of important social functions going throughout the pandemic. In the third wave, that we weren't sure in May if we would get a third wave, but certainly everyone is getting one. We first had the highest numbers, again, maybe because of extensive testing, but now we have the lowest numbers in Europe again, in new cases coming up. And we are currently planning massive immunization, vaccination, that we hope to get into place as early as possible in the new year. We don't know that fully yet. As other cities, we have done things, as you mentioned, Anthu, of opening streets. Kind of, we have allowed restaurants to take up more urban space. We already in 2012 introduced the concept of 15-minute city in our master plan. But our biggest task kind of in climate change is changing behavior in transport. So a lot of the things that we are dealing with in planning are still with us. And in the last 15 years, we have built out infrastructure that we could not have lived without. After the gyms closed, we've seen people crowding the walking paths and the bicycle lanes that have been built up the recent years. Well, going through my medical studies some time ago now, I tell the medical students, I give a lecture each year on urban determinants of health for medical students in Iceland as a mayor. But I don't recollect having got any kind of form of lectures or education on many of those points, very different from the doctors graduating 100 years ago that were very focused on good housing and the dangers of kind of poor urban development on the health of people. But the medical studies are to a large extent focusing on how to deal with diseases, but not the question of why people get sick. And I think that one of the points dealing with a pandemic is to realize that we are seeing in how it is developing and how it is hitting both cities and nations. We are seeing how kind of weaknesses that were there before when it comes to inequalities, when it comes to fragmented public health and health systems that do not focus on oversight and tight cooperation and communication. I mean, fragmented into kind of a lot of privatized parts that have no incentive to be a part of a holistic national approach or a citywide approach to public health. And I think the international society has to kind of notice this and do a lot of discussion and studies of how different approaches and different planning has been able to deal with this, because the effect we are seeing is that people are dying, people are of course out of work, and it has enormous economic outfall. But I think that some of the kind of knowledge that is piling up is a knowledge or reassurance that traditional public health with oversight and openness about data, about good, honest communication to people, and to be in a relationship of trust when it comes to information, when it comes to kind of relying on science and data is a big part of reaching the goals we want to reach at difficult times like pandemics, but also in other times, because I think that the problems we are seeing in this pandemic are also kind of key to understanding how we can get people more physical active or get people behind the importance of being a more equal society, both when it comes to gender or sexual orientation or income distribution, which is all key to having a good society, good public health, a good city, and a good life. So I think I leave with that. I have some great and different examples of how we work with health, with multiple stakeholders, but I think my time is up. Thank you very much.
Thank you very much, Maja Eggertsson, for such a candid presentation. I really take your point about equality, and I hope we'll be able to go back to this question of health equality in a city. Let's now go directly to the eastern part of Europe and turn to Vice Mayor Anuela Ristani. The city of Tirana had to face a devastating earthquake at the end of last year and then had to cope with an additional challenge of a COVID pandemic. We'd be very interested to hear about the measures taken to address the pandemic and their impact on the determinants of health. So Vice Mayor Ristani, the floor is yours.
Thank you so much for having me today. It's such a great an optimistic thing to talk about this connection that would be otherwise very natural between cities and health. Way I say it is one of the most common discussions we have with people is, you know, in such times of development and technology and advanced scientific thought, how come that we weren't able to face, you know, a pandemic or be ready or, you know, really reduce the impact of this devastating crisis globally? And the question is, you know, there are so much simpler things than really attacking a pandemic with a lot of unknowns in terms of science, because we already had data that showed us that health and urban development are so tightly connected, yet nobody had seriously put a thought into this in the way we plan our cities, in the way we design our streets, in the way we run our day-to-day lives. In fact, if you talk to any mayor today who is finally approaching science and research in the way they're conducting or how they're planning their cities, they will tell you that the mistakes that have been done in the last 50 years of city development are such that, it would take a long time to undo them and to really put us at a place where we could be able to offer to kids or seniors or to basically all the population an acceptable standard of living. Why we're saying that is because in the last 50 years at least, cities have been planned for the active citizen. They've been planned for the adult that is running from A to B, that needs to get stuff in a hurry, that needs to go into the office, that needs to be efficient. And we never thought about, his quality of life, her quality of life. We never thought about making it pleasant that way to work. We never thought about their possible interaction with their kids or possibly taking them to school in a human and not a machinized way of transport. All of those mistakes were not there to be, were completely avoidable if we had gone into if we had gone into the research that was out there saying that really health patterns are enormously related to neighborhoods. We find same diseases within certain neighborhoods that are exactly the same. It doesn't matter your upbringing, it doesn't matter your race, it doesn't matter who you are genetically. You tend to have the same chronic disease, you tend to have the same health challenges in the same neighborhood, and that is a fact, and that is something that was always there for planners or for us to really know and understand. But why was there this detachment between this data and between this knowledge and the way we constructed the cities? And we cannot do anything about what was done. But finally now we are drawn into this attention. And finally now we're understanding that this is directly connected to how we are handling the pandemic, how successful we are into tackling it. And, if we could mitigate those atrocious numbers that we are faced with every day, with deaths, with major consequences for the health of the whole population. Tirana is not unique into how we're handling what happened. I think all cities had similar approach. So I don't know. I don't want to spend much time into telling you guys social distancing and all that stuff that. If somebody wakes us up in the middle of the night, we know it by heart, what we should do if we get out of the house and, wearing masks and all that stuff. So that is not the special story here. What is special is that designing the city for everyone is actually designing a pandemic-free city. So the story of, how we're adapting to opening streets for people that they are safer, the story of how we are thinking about transport, and Mayor Eggertsson said, this is actually the number one challenge for all mayors today. That is not a story of the pandemic only. That is a story of making your city livable overall. It doesn't matter if it's COVID. It doesn't matter if it's, a pandemic, a new one that is going to come out. It doesn't matter if it's climate change. Your transport is something that is fundamental into changing it. And even if it wasn't for climate change, for livable cities, for healthy cities, and for cities that are not prone to depression and disease and really bad quality of life, this is the number one element of change that all mayors are looking into. And it makes sense. Why is everybody talking about transport? Well, because that is 50% of the contact we have with the city outside of our homes. I mean, if we're outside, chances are we're going from one place to the other. The other 50% is about entertainment, is about playing, is about, us consuming our social time outdoors. And if these two elements do not converge into a pleasant experience, then we're not going to be prone to be outdoors, then we're going to be less healthy, and then we're going to have less interaction and have less social and community life. So there's nothing special about, how you handle this pandemic, but there's something special about how you build your own city. Something that we were very highly encouraged here in Tirana was because we did start from real scratch. And just to illustrate how much scratch that was, in a city of 1 million, we had 0 playgrounds. Because we started from really the bottom, we had they call it the leapfrog advantage. So that, you know, you don't go through building major highways and then unbuilding them, and you don't go through building major subways and then unbuilding them, but you go through what is the latest solution for a city to be livable and acceptable and to promote health among its citizens. So the 15-minute city concept for us is actually less than 15 minutes. I mean, in Tirana is actually 5 minutes. And the reason for that was that, for better or worse, before the Berlin Wall would fall, and not because we were necessarily so much in the East, but because we were kind of like the North Korea of Europe, we were used to not having cars. So, you know, people would walk everywhere and they would take the bus everywhere, and you weren't allowed to actually have a private vehicle. So, you know, you made a life in a very natural and in a very biorhythmic way. And then that was forgotten because, you know, all of a sudden then you could have this trophy that was, you know, the capitalist symbol of you making it in the world. And everybody got, you know, fell in love with their cars. And this switched so easily into, you know, a city that was absolutely clean, no pollution whatsoever, into a city where basically, you know, if we're going to buy bread, like 500 meters down your house, you would basically take your car. When we got in the office, we counted that from the 800,000 road trips that people were taking with their private vehicle, 50% of that was less than 800 meters. So, you know, that was completely outrageous. That means that within 800 meters, you basically had all the services or all the main services for, you know, to access. And you do actually, because, you know, Tirana is pretty dense. It is 1 million, but the urban area is pretty concise and it's pretty concentrated. And you do have the health services, and you do have the pharmacy, and you do have your baker, and you do have a coffee and restaurant, and all those, and the school and everything like that. So that is there in place, let's say the system of accessing these services. What we need to change is the attitude. And like I say, we have like the major infrastructure project we say here in the city is not longer than 12 centimeters. And that is basically the distance from here to here. It's just basically changing your mindset. But changing your mindset doesn't necessarily just mean we have to work with the citizens. Changing the mindset also means how we develop the city. If you're looking around and you know, exploring development plans for different cities, you always find out that there is, you know, a certain area for business, and then there's a certain area that's residential, and there's a certain area that is for education. That is exactly what has hurt our cities today, because the mixed use of developing areas is what actually makes the difference into making a city livable and healthy, and making a city be hostage of this efficiency-driven and inhumane kind of lifestyle. We found out this was the solution before we were hit with a pandemic, before we were hit by the earthquake. And in every place that is being developed, so in every new area that we're being developed, and in every new development within the city, we make sure that there is a certain percentage of social housing, there is a certain percentage of residential, there's a certain percentage of services, and then there's a certain percentage of business centers. What does the mixed use mean for the life of the city? It means that in certain streets, you have life 24 hours. So, you know, the issue of security is there. It means that you could easily access one place with the other to combine both your residence and your place of business. So you don't necessarily have to commute long hours to go to, you know, the financial center if you're living in a residential area. It means that you could still have kindergartens and nurseries within these buildings when there is a mixed use of its areas. And then you could have services like, you know, restaurants and other services of entertainment within, let's say, your neighborhood. And all of these elements make not just the 15-minute, but like I said, the 5-minute city accessible. Now, I hear a lot of feedback from, you know, this the pros and cons of this, or like, you know, many people, they go for more residential and quiet areas, and, you know, they don't want to be close to schools, or they don't want to be close to businesses and stuff like that. But we all have to cope with living in cities now or in the near future. And living in cities exactly means this, you know, means that you are living in a community where you have a range of ages and needs. And what you do is you basically build, you know, build the structure to make them all combine their needs and their wants within this community. So, you know, obviously a lot of people would want to live on top of a mountain. That's always a choice. But the urban living and the healthy urban living is a living for everyone. It's not just, you know, for a certain margin of the community. Like you said, we went through a major crisis before this one crisis hit, and we are now at the stage where we have to build 3,000 to 5,000 new apartments for people who completely lost their homes, and they're living on, you know, rented. Well, we are giving them rent bonuses, so they're living in a different place. What we took out of this was, you know, if we're going to build one place here and one place there, why not just build whole new neighborhoods that are not just going to be serving these people who've lost their homes, and then obviously, you know, are the more marginalized, are the more socially vulnerable members of the community, but they are going to be, again, with the concept of mixed use, also areas where you could set up businesses, where you could have schools, and where we're actually moving public institutions so that, you know, you have space for office or for institutions that are, you know, employing hundreds and hundreds of people, so that you populate this area and you do not just make it for social housing, and you do not go into this trap of really this is the area of the economically vulnerable, and, you know, and fall into that, let's say, ghetto-ish compartmentalized type of living. The new neighborhoods that we're living, each of them has its own characteristic. One of the first one that we're actually constructing is by the river, and it's designed by Stefano Boeri. I'm sure you've heard of him. He's famous for the vertical forest, which is this concept of, you know, if we don't have space in the city to build forests to be flat forests, then let's just use buildings and make them as urban jungles. And he's designed them. He likes to call it now the COVID-free neighborhood, because what it means is that by using the intensity of buildings, and those of you who are familiar with, you know, these urban concepts, by using the intensity of taller buildings, then we maximize the surface below, and we provide enough distance from one building to the other, so that you can have small oases of space between you know, different residences. And also, because there is mixed use, you benefit from the fact that the majority, like half of the population then, for the free hours of the day, and so for, you know, afternoon, would have already left the premises, and this would be a lot more space for the neighborhood and a lot more space for the residentials. But at the same time, during working hours, also employees and people who are using this for their business function have these areas and have the space, and they're not confined into the urban only concrete jungle that might be typically downtown when we're thinking about business areas. I'm sure, yes, I'm looking at you, Anfu. I'm sorry that I'm taking much time, but it's just like a fun idea to talk about, and I'm glad we're finally sharing it at a, you know, viable level.
Sorry to interrupt you, but thank you so much, Vice Mayor Ristani, because you provided a lot of concrete examples about how, you know, to focus not only on an efficient city, but a very livable city, which with a mixed use of it, and therefore fostering equality within a city and improving the determinants of health. I'm quite conscious of time. Let's go now to France and see what happened with the city of Rennes. Charlotte Marchandise, you're not only the former deputy mayor of the city of Rennes, but you're actually also an expert on urban health, who's been working at the political level on health prevention and promotion. Floor is yours. And please be as concise as possible. I'm sorry if you want to allow for a bit of an exchange at the end. Thank you, Charlotte.
Absolutely, and thank you. I prepared slides, so that allows me to be a little bit more focused, but that was so inspiring, the previous talk, so thank you so much. So yeah, I was former deputy mayor. I stopped in last July, and that was something really useful. First lesson learned, I was at the end of my mandate when I actually was facing the COVID, and that was something that doesn't make the same approach as if I was at the beginning of my mandate, like my new colleague is now, the new deputy mayor for health. I also was president of WHO Healthy Cities Network. I won't go into details because Monika will, but that made a whole difference in the way we tackle the COVID crisis in Rennes. Rennes is in the west of France, for those who don't know this major city. 250,000 inhabitants, metropolis about almost 500,000 inhabitants. It's been a WHO healthy city for 30 years. So we have partnerships, we have lots of data, mapping. We mapped during our mandate inequalities, social inequality, health inequalities, primary healthcare offer. We developed massive approaches in healthy urban planning, and what you're saying about Tirana goes really what we were trying to do. How do we make a livable city? How do we take into account women, kids, elder people in win-win approach, promoting that the more we adapt the city to the most vulnerable, the more it's good for everyone. We have also lots of things with communities, lots of things in neighborhoods, because we know they don't have the same needs depending on the population, depending on the urban environment. So we've been working a lot with population all around the last 30 years. And for the past 6 years, I created and developed with my team lots of partnerships. We also developed the health in all policy approach. So I really advocated to make public health something important for urban planners, for people in transportation, in education, in culture. So that's what we had. We're able to identify much more easily the people with needs in deprived neighborhood, for elder people, because for climate change, we already worked in trying to find the people that were vulnerable when we have heat waves. So we knew where they were, we knew how to gather them. We already had solidarity with them and communities helping each other, so we could mobilize them. We have lots of work with people with mental disease, and so we have lots of work with the mental health hospital. So we were able to create, not overnight, but almost a telephone hotline for psychological support. We distributed masks, and there were a little mistake in that. The first masks we distributed that were done by people from the region, women, and we tried to do it very ethically. That was really not accessible for people, for elder people, for kids. So we learned from that, and the new masks have, elastic things. We distributed computers because, of course, not all the kids were able to have computers. Sometimes the family, they have one computer and 4 kids at school. Sometimes they don't have. And we also helped a lot the economical actors. Of course, like everyone, I won't get into it. We did Corona Pass, we did Corona Street, trying to promote active mobilities. We were helped on that because we had been working on air pollution for the past years. We had air ambassadors that we empowered with sensors. So we had lots of material to promote that. We had lots of bikes to distribute. We had bicycles in deprived neighborhoods. So it was something that we were able to deploy quickly. What was really strong for us is belonging to WHO French healthy cities and WHO European healthy cities. Because we had meetings, we were able to map what we're doing. What can we do with the parents? What can we do with the and learn from each other in a very agile way. We could call each other because we knew each other. And, all mayors have been through that during this crisis. Lots of them at least didn't get help from the government. They get help from their fellow mayors and deputy mayors in the countries and within the world. We learn from each other, and that was crucial. So what's next? Because you asked me to go a little bit further than the city. Well, political processes and decision-making are complex. We've seen that all countries and all cities in Europe made different ways of answering. And what we're going through now in France is massive distrust of public opinion in decision-making. We have large problem of trusting what governments are doing. We have much less problem in local government. Mayors are much more trusted. But we have to acknowledge that decision-making is not something simple. Decision-making sometimes is based on evidence-based, on academic research, when the research is accessible, when the mayor or the minister is able to read the research. And sometimes we're just elected, we're not specialists in public health. We cannot read a thesis of epidemiology. We need cortege, we need something that mediation between politicians and academic. Political decisions are also made of social movements, of values, of the media, of the economical interest, of the local competition. So we need to take all that into account if we want to change the way political decisions are made, if we want to. You cannot say, oh, mayors has to release on evidence, mayor has to do a sustainable development goal. We need something much more adapted to the cities. So if health is a political choice, how do we empower politicians, stakeholder, community? Well, we need communication that is easy. I mean, this one, user experience and design, I think it's the best advocacy ever to tell people, well, first reach out to community, because if you design something without the people, well, they won't do it the way you want. And you will lose money, you will lose time, and you do against the people, and you lose the trust. So, I mean, even if you're not someone working with communities, you understand this drawing. But this is true for any policy we make. We also have to make public health great again. We're not the sexy deputy mayors as health mayors. We often, you don't smoke, you don't drink, you have to take a bike. It's not funny. So we have to show that there are co-benefits. When you have less car, you walk more, and people in streets with less cars going, they have more friends in the streets. So when we face a pandemic, when we face a natural in urban health, and you can see that when you have a flood, massive flood, where they had strong communities, they reacted much better. So less car is having better community that are empowered and ready to act upon crises. So networks are keys for COVID, for next pandemics, for climate change. So I think we really need new city diplomacy, really have ambassadors, because diplomacy is made out of ambassadors, not only technical people, not only talks. We need in between health people, but talk to all the other people that have the levers. Thank you. Hope I kept the time this time.
Thank you so much, Charlotte. And sorry for the audience. I think we lost you a few times. We still got your message about, community engagement and the need to infuse trust again has been heard. Now that we've heard from city leaders and how they work concretely to improve the determinants of health for their urban dwellers in a COVID context, it would be very interesting to hear from the UN agency mandated to address urban growth and its sustainability, how health is considered in all of that. Graham, you're representing UN Habitat today, and the floor is yours.
Thank you very much, Antu, and thank you very much I'll be as quick as I can, but it's nice to see so many of you, and thanks for the opportunity to the City Hub. I mean, I think I'm preaching to the converted, but many of you know that this idea of urban environment and health is not new. And if we go back to some very classic sort of planning arrangements, like the grid system of roads in Manhattan that was, built in the 1870s before there were any motor vehicles, that was actually done as a public health intervention, because they, in those days, thought that, the miasma theory of disease was related to poor air. And I mean, there are examples of that are around. But I mean, I think that even today, this understanding that, health is made at home and, the hospital is for repairs, is becoming more and more important. And you know, if you look back at history, we've got lots of lessons that we can learn from that. Mayor Eggertsson says if you go back before before antibiotics were available, you know, there were very good procedures in place for dealing with disease epidemics, and the sorts of social distancing was what they had to rely on in those days. But I think the COVID crisis has been quite interesting, because in some ways it's been an X-ray, for want of a medical analogy, and that it's shown up even more where the inequities exist in cities. And, you know, the only way that you can find that out, as the previous speakers and mayors have said, is that you must have this disaggregated data, not only on the health patterns, but also the environmental determinants that affect the transmission of disease. So, you know, we've been doing some work at UN Habitat because, of course, everyone thought, well, urban density, you know, high transmission, this is very bad. But it's not actually density, it's about overcrowding, and it's about using that space properly. That I can share with you a paper of some results that we've done recently, which shows these issues and how, and we tried to compare different cities around the world and what's happened. The other thing which people haven't really picked up on yet is that if you go to you know, African cities, and if you look at the COVID, the way COVID has been starting to spread there, we find that, you know, large proportions of the low-income populations are younger. So the whole transmission dynamic is very, very different. So we need this information if we're going to protect the elderly in those communities that are predominantly young communities. It needs a different approach. So this data is absolutely key. Access to basic services, access to water, sanitation, drainage, all the classic public health interventions that we've taught. But I mean, I think perhaps the most important thing, and again, the mayors have said this, is the idea of health being needing this multi-sectoral approach at the urban level. You know, as one Assistant Director General at WHO used to say, you know, they're not ministries of health, they're ministry of disease, because they don't work on focusing on actually sorting out, you know, the causative agents that are causing the disease. I think another very important thing about the COVID crisis, it's shown this critical relation between communicable and non-communicable diseases, and the impact that COVID has had on lifestyles, not just from the point of view of exercise and enabling people to keep fit, but also the way that it's impacted on people and their treatment-seeking behaviour who have other chronic diseases and have not been able to get access to services. So, I mean, you know, it's very, very clear, isn't it, that, you know, good urban design, it has to be the way ahead, it has to be sorted out. And the other thing which, like, a lot of people have forgotten about is that if we don't do something about this now, the burden and legacy in the future is going to be terrible. In many European cities, my country, where I used to live many years ago in the UK, we're a hugely aging population. If those people become old and they're infirm and they suffer from chronic diseases, from diabetes, from obesity, from coronary heart disease, the state will not be able to manage the health crisis that faces them. So it's really, really important that we address that now and ensure that the younger generations don't grow up in unhealthy lifestyles. Aside from, of course, the tragic results of the loss of life under COVID and the loss of productivity and the economic impact, there's this long-term legacy. So what can we do about it? I mean, I think there's two big areas that, I mean, we need to focus on. One is the idea of urban design and preventative health, which I think all of you have talked about. But one area, and I think this is particularly important, not just in the developing world, but the developed world, is unlocking the resources that are available at community level to do this. We've heard good examples already, and Charlotte mentioned about this huge opportunity to build a community to support this community health service. And this is the same. It can be applied whether it's in Rennes or whether it's in the slums of Nairobi, because it's in everyone's interest to sort this out. So I think really there's two very clear paths that we have to follow. And I mean, the Healthy Cities Network has already been pursuing that. In terms of Habitat's work, I mean, you know, our mandate is on sustainable urbanization, which is, of course, embodies the concepts of a healthy city and a green city, a low carbon city. But there's also opportunities with slum upgrading. We know that by improving the conditions in slums, that we can reduce these huge health inequities that exist. So, of course, a lot of our traditional mandate of dealing with slums, of making cities more inclusive, becomes very, very important. And again, that's not just about the global south. There are many situations and huge inequities that exist in European cities and other parts of the world that we need to address. Habitats worked, of course, we're working with the Cities Hub very closely, but also with WHO. We produced some guidelines on urban planning and health. We also work with them under the COVID crisis about providing checklists and guidance notes for local authorities in managing the COVID crisis more effectively. I think this is a good example of a win-win opportunity. If there's anything good that can come out of the COVID crisis, it highlights and underscores even more the necessity that we have to deal with health in a very radically different way to what we've been used to. We have to learn some of those lessons from the past, before things like antibiotics were available, and we had to get back, as Mayor Eggertsson said, to some key core public health issues. My final comment is really a bit more forward-looking in terms of what the future holds if we're careful. I mentioned already about the burden of non-communicable diseases. This, of course, is one of the biggest worries, not just in the developed world, but the developing world. But the other thing is we need to be more aware and more understanding of the future risk that exists. If we look at cases of other epidemics, in this case of disease, we were usually caught unawares. If I cast your mind back to not so long ago when the Zika crisis hit Brazil, it spread by the same vector as transmits dengue. It was traced back to a management of the environment conditions in the favelas, which was actually providing the reservoir for the transmission of this disease. Simple interventions would have prevented. This wasn't a terrible epidemic, but it certainly was bad. But if we look at that, I'll give you perhaps another example to think about. Yellow fever, another example. We have a good vaccine for yellow fever, but we don't have a treatment for it. Yellow fever is endemic in many African countries and in African cities. If the disease transferred to Asia, where the vector is present, where people aren't vaccinated, we could be faced with a tragedy. If you look at the complications around some of these diseases, dengue can cause hemorrhagic fever, and you get a proportion of people who really suffer badly as they have under COVID. So we need to understand that these issues aren't just about the cities and countries alone. They're understanding, and this is in fact what happened in the COVID pandemic, it was translated across continents. There's still the risk that if we don't look at things carefully, we can transfer some of these other diseases, and we need to be more mindful of what the future holds and what we can look at. So I'll stop there, and thanks very much for your attention.
Thank you, Graham, and thanks for reminding us, as did the other speakers, that really the COVID pandemic was a magnifying lens on many issues that have to be dealt with, and we have to take this as an opportunity to basically build back better. Last but not least, Monika Kosinska, I hope you've got the sound back now, yeah? Can I also simply encourage the panelists to look at all the rich material in the chat and try to see if there are things, comments and questions to which you would like to respond to, so that we can have a bit of an exchange afterwards. Monika, the floor is yours.
Thank you very much, and good morning, everybody. Thank you for the invitation to be here and to join such an excellent panel and a very rich discussion. So I'm going to talk a little bit about what we do here in the WHO European region and the network that we have, the COVID response that was the network was very important for us in terms of partnership. And then I want to talk a little bit about what's happening next week in our annual conference. So we have our meeting next week. So first of all, a lot of what we've heard already, the Healthy Cities movement, they had the origins, the priorities. This was institutionalized for us in the European region already very long time. ago. So 33 years ago, the European Healthy Cities Network was launched. It started with 8 cities. We now have 1,500 municipalities across the European region, and this includes flagship cities such as Reykjavik, and it's great to be here with the mayor, also Tirana, but all the way to small municipality and hamlets. So these are organized through national platforms that we don't work with directly, but we go through national associations and national networks of cities. And I can see we have, for example, the Russian Federation present with us today, one of the largest and most important that we have. And this for us as WHO is a very important mechanism. 75% of the population of Turkey live in a healthy city, for example, through that mechanism. So and we're very demanding. So a city that joins the Healthy Cities Network, it normally takes 2 years for them to apply. We ask for a city health profile. For some cities, this is something they have. For some other cities, this is something we have to help them develop. We ask for a health plan, a health development plan, an intersectoral one. We ask them to set up an intersectoral committee if they do not have one to prioritize this. We ask for this to be under the leadership of the mayor. We ask them to undertake an analysis of how health is reflected in their development strategies, and then we ask them how they're going to monitor and evaluate this. So this is significant, and Evelyne at the beginning showed a little bit about the evaluation of the processes. She's been an important part of that for a long time now. And the key characteristics of the Cities Network is threefold. So the first one is political leadership. It's absolutely critical. We know what has to be done. We know it. We've known for a very long time. The 11 elements that Evelyne presented are just as valid today as they were. We still have not got this done, but we are coming close if we do it from the local level. And political leadership is absolutely critical. Without it, we could not have done what we've done. Number 2 is technical excellence, both within cities, but also across cities. Smaller municipalities do not have the resources, the large ones. When larger cities join the European network, we ask them as a solidarity commitment to provide their resources to share their knowledge and expertise with others. So this peer-to-peer learning and sharing is vitally important. And of course, us as WHO, we are part of that process and our partners with other UN agencies as well. And then finally, community participation. It cannot be done without involving people in the decisions that affect them. So these 3 dimensions are fundamental characteristics of what it means to be a healthy city in the European region. Now, I want to stress again how important this is as a partnership platform for this. This is not an academic discussion. We know what the issues are. It is the translation of this into action at the local level, and cities are our partners for that. And this was no more visible, or you could not see how important this was more than under the COVID response. So back in January, I was involved in the emergency response team here in the European region, and we repurposed the Healthy Cities Network to support the WHO emergency response in the European region. So this is where already at the end of January, we had a first meeting with the cities that were part of the network to present what was happening in other parts of the world. At the time, it was not yet an issue for us in Europe. And then very quickly at the beginning of March, we mobilized the network as a response mechanism. So me and my team, we met with the cities every 2 weeks. We update them on the COVID situation in the European region. We provided it as a forum for sharing of learning. It was very rapid, very quick. What was happening was very different. There was not a lot of centralized information points. We were able to provide that for cities. We had cities attending regularly from over 40 countries in the European region, and using us as a way to access information, access resources, and also support their own response efforts in that. And this allowed us not only to be part of what Graham mentioned. We developed a checklist as the WHO in partnership with UN Habitat and others, and us in the European region. We were the technical resource partners from our side, engaging cities and validating as well to make sure that what we published was going to work and be useful for cities at the local level. But I think what it was also important is that we were able to use our convening power to allow people in a very vulnerable moment. Cities were so overburdened at that time. It was so humbling for me and my team, even if we were ourselves working on the response efforts, to be able to support individuals who were frontline respondents at that time. And if I go, we've undertaken it's a very desktop exercise, the horizontal analysis of what has come out of that process process. So the reports that we have from the meetings, I think we have 13 or 14 reports at the moment, and there are 6 very clear themes that came out from cities, and I just want to share them with you very briefly today, and then I'll move on. The first one is vulnerabilities. We know that, we knew that at the beginning. We knew that this was running through the vulnerabilities within our populations. People who were already having difficulties, people that were hardest hit and most at risk. And the cities were phenomenal in responding to that need, in reorganizing services and providing support to those who need it, in finding those who needed it. However, one of the main lessons that was learned from cities, which we knew before and it was validated, is that you could not build whilst you were putting that fire out. So the community mobilization, community relationships that were in place were able to be used and repurposed for COVID. If they were not there, that was much more difficult. So that's 2. The third was the spatial reorganization of cities. Cities changed the way that they interacted with their people very quickly. Things that would take years before in terms of reorganization of transport systems, reorganization of public spaces, suddenly that all became possible. We can do it if we want to, and that's a very important message. The third was the community and social resilience measure as very important to well-being during this period of time, investing in being able to support people to still maintain their community relationships, their social relationships, and as a marker of resilience, of social resilience in that period. The fifth was leadership, coordination, and governance. Cities do not work in silos. I mean, you mentioned this at the beginning. Cities do not do that. We do that as the health sector. We do that as national partners as well. The cities do not. That cooperation is natural. It's part of the ethos at the city level. The challenge for the rest of us is how do we support and enable them to do their job? And that's the final one that came out was the economic measures, both in terms of the rapid response and building back better. The critical need for cities to be able to access those resources, use those resources in the way that they know what their needs are, and ensure that those resources commit to a sustainable future, so we do not have any regrets in what we're doing in our investments at the moment. So I've been very, very brief on that. And the other thing for us, it's a reflection for WHO, our partnerships. I mean, obviously the cities are our main partners and national platforms of cities, but also our UN partnerships are critical here. So the support from UNESCO, the support from UN Habitat, the IOM, the International Organization of Migration, the UNDIR, the UN Disaster Risk Reduction Agency, they all came to us, with us, and we were able to work together as UN agencies, but again through the platform that was already there, which was the Active and Engaged Healthy Cities Network. We invest in providing that platform for the cities to be able to work together. This is not ours as WHO. We are just there to facilitate and convene. But that mechanism and allowing us to support cities in that was tested and was very important during this period of time. So next week, I'm delighted, sorry, I'm speaking very quickly, but I know we're short on time. Next week, we have our annual governing body. So the network convenes on an annual basis to take decisions on some of the business matters, but then also has an exchange on technical and scientific content. We have 37 sessions over 3 days, which we're looking forward to that challenge, including some fantastic plenary speakers. I'm going to mention them here. Graham is going to be there. Thank you very much, Graham. We have Tom Frieden. We have Janelle Puthchieri, the Senior Minister of Health from Singapore. We have Professor Mazzucato. So please do join us for that, as well as of course the mayors and city leaders from across our region for that as well. But the content of that is going to be reflecting on COVID. So what did we do? How did we do it? Some phenomenal case studies from the city level on how they responded as quickly as they did. The logic is over the 3 days. Day one, we talk about the preparedness. How prepared were we as a community from the local level to the international level? How can we learn and do better from that? The second is the response. We reorganize places, we reorganize services. Again, how can we institutionalize and create some sustainability about that? And finally, the third day is building back better. So what do we do going forward? And I just want to end saying how important and our inter-regional cooperation. So I work for the European region, as I mentioned, but my partnerships and our partnerships, both at the WHO level with the other regions, as well as the national to city level, is also very important. It's us who have delineated cities into WHO chapters, of course, in that way, but that international cooperation is critical. Cities are global actors and not only regional ones. So I want to thank Charlotte's leadership when Charlotte was president of the French Association and the vice president of the European network. She was very active, and under her leadership, we had some activity I don't have time to talk about, but between the European region and the African region, so France and a number of countries in the African region. We had at the UN General Assembly, the cooperation between Portugal and Cape Verde was awarded a prize for establishing the first national network of healthy cities in Afro. The Euro and EMRO has a long-standing cooperating relationship, particularly most recently on Iran, and then we have Iran and Greece, forgive me, and then the Portuguese Lusophone supporting network as well. So we have some excellent city examples for cooperation. I'm going to put in a plug from our Global Healthy Cities sessions, which is running on 2 days, so that we can have both participation from the Americas and also from the Western Pacific and the Southeast Asian region. The Mayor Eggertsson is speaking at that session, which is, and thank you very much to the Mayor. We have,
Monika, I'm sorry, I think I really have to cut you there.
Yes,
I failed miserably with time management, and I understand that Nathalie Rebel from WHO also wants to make a few remarks, and then we'll wrap it up. I'm sorry about this, but really time is over. Sorry, Nathalie, floor is yours.
Thank you very much, Antu. And I'm going to be super brief, because I just want to build on what Monika was saying, and just saying that WHO, the role that urban health has been playing, right, is been a long-standing investment and understanding of the importance of urban health. And we have heard about the amazing work on the Healthy Cities Network, but certainly there has been many other entry points by looking at specific interventions, sectoral interventions, and supporting countries with guidance, or building tools to do health impact assessment, and many other areas. I don't want to go in detail. But I think the reason why I want to mention this is that in WHO, there has been now even a strong recognition, strategic recognition of the role of urban health within our global program of work. And this has actually translated even in the creation of a function under the social determinants of health, umbrella, really a function that will help to coordinate WHO's work on urban health, really building on what has been done, but putting it under a framework in order to even better support countries, right, at the local level to address well-being and health. So this is just to reinforce that from a WHO perspective, urban health is really a key priority and will even be more. And I saw in the list of participants a lot of colleagues with whom we have been working over the last, I would say, decades. And I'm already looking forward, to consolidating this work and being able to shape a real urban health framework, a real urban health program. So that's all from my end. Over.
Thank you so much for being so brief, but your message is very clear. And I think it's a great news to hear that WHO will, even reinforce its work on urban health. I want to leave a last chance for a few panelists if you want to make any concluding remarks about, in particular, about the exchange in the chat. Is that the case for anyone who would want to make one point, one last final comment? Is that the case? If not, I'm very sorry. Again, I failed miserably with time management, but I'd like to say, I was very impressed during the discussion to hear all the work that is being ongoing in the cities, at WHO level, in UN Habitat on urban health and the determinants of health. But I think we still, need to basically take that work and for it to trigger up, if I may say, to the global policy level here in Geneva. So I hope this is only the beginning of a conversation, and that all that experience that you have basically in the field can be brought back to the policy level here in Geneva. I'd like to really thank once again all of the panelists for your contributions, your interventions, your examples, you have all demonstrated how much energy, commitment, leadership, creativity is needed to improve the urban determinants of health. And thanks for taking part in the effort to put the issue of determinants of health on the global agenda. The Geneva Cities Hub will organize other urban talks, or urbiners, if I may say so, aiming at bringing the urban dimension into the work of International Geneva and gathering the actors interested into urban issues. Okay, so, and I understand that Graham, you want to, sorry, Graham, you said you wanted to attach your paper or something like this? Unmute yourself.
Okay, no, I just had a paper that we've recently published on COVID and slums, but I can't quite work out how to attach it in the chat. So we'd be grateful if you could send it on to everyone, please.
We can definitely do that. So thank you once again. Sorry we haven't been able to have a good interactive exchange. Hopefully we can do it next time, but stay tuned for another urban talk. Thank you very much.